website at metalytics.webs.com. Metalytics, delivering faster, economical, and patient-level healthcare. Any questions?
Congratulations. You know, I have to admire you guys. Picking up a business in the healthcare environment is complicated, as you know, particularly as it relates to trying to present what it is that you're going to sell. So without having to bog you down, I think, you know, understanding a bit more about the product and what it would have looked like and how physicians would use it would be helpful. For those people who are not close to the issues in the space, it's difficult to see what you're trying to solve. But my sense is that the differentiation you have is around the data. And you mentioned the patient-to-patient parameters that you believe will be unique to Metalytics. Are there any data concerns? How do you think about why it is you all can provide this level of uniqueness from some of the bigger players that are listed on the slide?
Well, when we have the data, we actually use Bayesian analysis, which allows us to take the posterior probability, where we get that from the prior probability, which means that historical data. So as more data is collected, we are able to get more predictive, better predictions because we have previous data. So we actually have a CEO in West Florida, our advisory. He's the CEO of West Florida ACO, and he has looked at this product and he said that this is a very good opportunity for him to use this type of tools to help lower his healthcare costs. Because in 2016, Medicare is going to be penalizing hospitals who are not turning to value-based care.
I actually also, going along with Rohan, not only will hospitals be penalized if they do not switch to value-based healthcare, they will actually be generating more of an income because before, let's say, hospitals have about 2,000 active patients, and they're spending about $5 per test per patient, and they're generating $1 million in revenue. But insurance companies they have an expenditure of $10 million for that. So if insurance companies tell them to get their incentive, and if they tell those hospitals save 50% of your tests, so and we can give you 40% of our savings to you. So by the end of that, the insurance companies, if those hospitals switch to value-based care, and if they reduce their tests by 50%, then insurance companies will be saving more, and doctors will be generating more of a revenue if they get 40% of more savings from the insurance companies.
Okay, is the nurse practitioner going to use your software when an incoming patient comes in? I didn't understand exactly how you're altering.
Okay, so when a patient comes into the office and they have a regular checkup for strep, the nurse will be the one who checks their symptoms, like if they have a sore throat or if they have what their fever is, and the nurse will be able to put these numbers onto the system, and they can generate a predictive number like 30% what we had before of their chances.
So you're going to give some piece of software to this ACO organizations that somehow you realize how hard it is to give a piece of software to particularly the ACOs, because they are so fragmented and distributed. Unlike, I can see a large hospital, at least you have a chance of installing the software a little bit more easily. Not that they are very easy, but the ACOs will be the most difficult ones to go after, particularly when you want to bring a piece of software. So this is completely independent of the fact whether you have some fantastic technology or not. Thomas Bayes incidentally gave that formula 250 years ago. So there is very little you can get in terms of patent protection. But wouldn't matter. The biggest key problem to solve here would be how would you get your software in these ACOs if that's your market. Because that's a fundamental important. If you can get that, then the rest of the numbers will speak for itself. But that's going
So we're gonna first be integrating with EMR and then by, for example, going to ACO conferences, using any personal connection. We're going to be targeting the operations side of ACOs because they would understand the economic benefit of our product.
Yeah, and going along with Divya and Rohan, we're actually starting with smaller ACOs, so the smaller hospitals and the physician practices, because we know it's harder to integrate our software with larger hospitals who have the capital budget and who can spend more money on other technologies. But we feel that this technology is most beneficial to smaller hospitals and smaller physician practices. And we actually already have we already have data input from West Florida ACO, and they've agreed that they're actually the first people we will test or we will pilot our technology with for the first 6 months. And going from there, we will pilot more smaller ACOs in Massachusetts, and the number of ACOs in Massachusetts alone is about 18. So we will pilot them, and then we will see how much of an economic benefit it is to them.
Great presentation, and I really like your three lenses vision of that in terms of looking at the desirability, the viability, and the feasibility. Within that, I mean, and maybe to follow on the last point around your kind of sales strategy, like, so I understand going to conferences and other stuff, but a lot of times in fields like healthcare, the sales cycle is pretty long. It could be a year, who knows. How do you think about that and what's your approach to selling to the ACOs beyond conferences, like direct selling, how will that work?
Well, in our income statement, we're piloting first for the first 6 months, and we want to integrate with the hospital's budgeting process, so they can see the benefits to our technology. But since we know their budgeting process is quite high, we want to pilot for the first 6 months, and we want to make sure our pricing plan fits with the capital budget that is available in their budgeting process, so they can invest in our technology.
Well, congratulations for taking on such a tough area, just as the other judges have said. I'm sure you guys have learned a lot during this process. So I have a lot of questions. So I guess Gopal will stop me when we run out of time. Let's start with why strep? Why did you choose strep as the example?
Well, strep is a very common non-threatening disease, and non-threatening diseases are what we're focusing on, and we were able to find a lot of data on it, so this is why I used it as an example.
But I was, my kids kept getting strep all the time, so I guess I'm a parental expert in strep, rather than a medical expert. But I'm thinking, if you think about the quick strep test, that doesn't sound, you eliminating that doesn't sound like the biggest target you could go after. So for instance, one of the big issues we have, obviously, is giving out antibiotics to people who don't need antibiotics, and that's a huge societal issue. Now, maybe that's too big an issue to take on, so I'm not saying you should have done that, but did you consider it, I guess, is my question.
We did not consider the example that you just gave, but the reason why we chose strep was that it is actually the most common unnecessary test that is in hospitals right now. And what we want to do is we want to free up, because not only are there unnecessary tests, there's also a lot of manpower in lab supplies, and we want to free up man labor on less acute tests like strep tests, and we want to make more manpower and supplies, as well as more money available for more acute testing.
Okay, I think until you answered a question, the words insurance companies weren't mentioned in your presentation until you answered a question a few minutes ago. I don't think you can do a presentation like this without talking about insurance companies, because those are the major players, major financial player in this in this little business. So it's interesting why there wasn't more focus on insurance companies.
Yeah, just to go along with that,
Yeah.
our ACA is completely based on insurance, hospitals. But even if we sell our technology to insurance companies, they will implement it in hospitals anyway, because we don't. With the ACA, we don't sell directly to insurance companies because they don't have the data that hospitals have. But let's say if the ACA, let's say if hospitals don't turn to more value-based care, we would go to insurance companies directly.
I'm not saying you should sell to them directly, but that's the organization that's got the most financial benefit from us eliminating unnecessary tests,
Right.
from what I understand. So.
Right. To add to what John B just mentioned, before the passing of the ACA, insurance companies would have still benefited from this product, but the hospitals had no incentive to have this sort of product because
Right.
the more tests they ran, the more income they would generate.
Right.
But now, due to the passing of the ACA, they actually benefit. So we sell to the hospitals because, as John B mentioned earlier, they are the ones that actually have the data and actually can use this product. And before, the reason why it didn't work was because they tried to sell to the insurance companies. But the insurance companies would benefit, but they cannot tell the hospital to use the software. So since the hospitals had no incentive to use it, they didn't use it before. But now, because of the ACA, they do.
No, you guys were very good at that. Very good in your explanation of that. So I got that. So well done on that part. I guess last question before I get cut off. Don't you have to run some kind of trials to prove the efficacy of your software? And I didn't see that in your plan at all, because I'm not sure that I want my kid diagnosed by some unproven software. So don't you have to run some patient trials?
Yes.
Yes, we will actually beta test our product at smaller physician-led ACOs, and we plan to do that by by having our salespeople as well as ourselves personally approach hospitals' IT teams to present our pricing plan and to present our economic value, and we will give them the opportunity to beta test during our piloting for 6
So I'm
months.
talking a little different than a beta test. I'm talking about some clinical trial that proves that your software works, under a very controlled situation, probably administered by some kind of research organization.
Yes, so we have approached the West Florida ACO, and he does believe that this product can be used in his ACO. So he is agreeing to use this product, and then he's gonna, after 3 months, we're gonna see the actual the benefits that we've given